deficiency characterized by severe decrease in insulin, absolute decrease in insulin, which is more commonly seen in the type 1 diabetes than undiagnosed type 2 diabetes patients. The etiopathophysiology on top of diabetes mellitus, the patient have acute stress. Due to that, there will be increase in counter-regulatory hormone along with absolute decrease in insulin levels, which leads on to lipolysis and proteolysis, which leads on to at final ketoacidosis and dehydration. Then the symptoms we saw acute abdominal pain, shortness of breath, nausea, vomiting, thirst. The signs we saw acidotic breath, Kussmaul's breathing, apathy, and confusion. The patient can have features of shock, that is reduced GVP, hypotension, and tachycardia. The investigations we see urine examination, we see glucose and ketone bodies. On doing RBS, we see glucose level between 250 to 600 milligram per deciliter. On serum electrolyte estimation, we can have hyperkalemia, hyponatremia, and decreased bicarbonate levels. The diagnostic criteria is plasma glucose level more than 250 milligram per deciliter, pH less than 7.3, sodium serum bicarbonate levels less than 15 milliequivalent per liter, and the patient will have ketonuria and ketonemia. Then we saw the treatment. We'll insert 2 IV lines. One we give NS and another we give regular insulin. In that we replace 3 liters in first 3 hours, followed by 3 liters in next 9 hours, followed by 3 liters over next 12 hours. After 1 liter of fluid, we'll give 1 ampule of KCl after insulin stat dose. Okay, the insulin, coming to how to administer regular insulin, will give stat dose of 0.1 unit per kg, that is IV bolus, followed by IV infusion of 0.1 unit per kg per hour. We'll monitor the blood glucose each hour. When the blood glucose level reaches less than 200 milligram per deciliter, we'll shift on the fluid from NS to 5% dextrose, and the insulin dose will adjust from 0.05 to 0.1 unit per kg per hour, so that we to maintain blood glucose